Okay, hello, welcome everyone. Thank you for joining us today. Our topic is collaborative pathways to value-based care in rural healthcare, building successful partnerships and strategies. My name is Cassidy Avila. I'm the program coordinator for the Texas A&M Health Rural Engagement Program. Before we begin, I will let you know that we are recording the webinar. We will share a copy of this recording as well as the slides with you in a follow-up email from the Rural Engagement Program. We'd love to hear your questions and comments, so please share those in the chat as they come up, and we'll make sure to address them at the right time during the webinar. Additionally, we should have some time at the end to take those questions as well. Our moderator today is Rayanne Davis, and we have 4 speakers who will be introduced before their presentations throughout the webinar. So let's just kick things off by introducing our moderator, Rayanne Davis. Rayanne serves as the Director of Value-Based Care at Texas A&M Rural and Community Health Institute. She oversees the population health team that supports the transition to value-based care for rural healthcare providers in Texas. Rayanne works collaboratively with rural providers and hospitals offering services that empower and strengthen their value-based care operations and expertise. She has over a decade of value-based care executive leadership experience, including operating clinically integrated networks, accountable care organizations, leading the network operations team at managed care service organizations in Medicare Advantage and commercial, and operating a high-performing provider network in risk arrangements, including capitalization and subcapitalization. So Rayanne, we are thrilled to have you moderating today, and the floor is all yours.
Thank you so much, Cassidy. I am thrilled about our panelists today and our presenters. We have a great panel of industry experts for today's webinar. Rita Lewis will share valuable insights into our rural collaboration aspects of value-based care and alternative payment models. She'll share national trends, resources, and initiatives. Then we'll have Zach Davis will speak about accountable care organizations and considerations for partnerships and strategies, and help identify improvement opportunities within an ACO. And then bringing us even closer to home, Paul Aslan and Melissa Matlock will discuss Texas partnership opportunity in value-based care and clinically integrated networks. So please feel free to ask questions throughout the presentation. We intend to have time for a Q&A session at the very end. But before I get into the formal introduction of Rita, let's take a closer look at some key terms and accountable care structure that'll help us in context of our presentation today. So what is an accountable care? Accountable care is a person-centered care team that is taking responsibility of a patient population. Accountable care organizations are those groups of doctors, hospitals, healthcare professionals that are coming together to provide patients with that high quality coordinated care across the continuum of healthcare services. And value-based care, when we talk about value-based care, it's really designing care so that it focuses on providing that high quality of care, looking at provider performance and patient satisfaction and experience. Accountable care organizations are there and formed to succeed in delivering these high quality care and spending healthcare dollars more wisely under the ACO. Typically, when we talk about accountable care organizations, this is specific to our Medicare programs, traditionally fee-for-service. So not Medicare Advantage, but your traditional original Medicare fee-for-service populations. The CMS Innovation Center has developed many different models to test new healthcare payment and service delivery models. There are different options for participation that allow ACOs to select an arrangement that makes the most sense for their organization. And we're going to talk about a vast continuum of different models today as Rita explores those models and Zach dives deeper into considerations when you're looking at accountable care and alternative payment model. But before we get there, I just wanted to provide a little bit of history on the Medicare Shared Savings Program, because I think that's going to be a topic throughout each of the presenters' presentation today. The Medicare Shared Savings Program in 2024 had over 480 ACOs participating in Medicare Shared Savings Program. And this is specific again to Medicare fee-for-service. The goal is to have continued accountable care across Medicare and Medicaid beneficiaries in some sort of ACO model by 2030. And most significantly, in 2024, there was a 27% increase in rural participation in ACOs, over 9,000 FQHCs, RHCs, and critical access all combined. So I just wanted to give a high-level oversight of what the dynamics look like under an ACO. That'll provide a little bit more context as we move along in the presentation. So an ACO brings together those providers, hospitals, specialists, healthcare providers into an ACO network. And then they contract with Medicare through these alternative payment models that we'll be exploring today. And they're usually led by a clinician governing board of those participants in the ACO. And then based on the participants, providers that are participating in the ACO and the patients that they're seeing, those are the patient population in which you're looking to manage that high quality of care and reducing costs. So why are we talking about this today? If you're not already participating in a Medicare Shared Savings Program, the deadline to participate for 2025 is up and coming. And so by August 1st, you would need to join an ACO to participate in a Medicare Shared Savings Program for the performance year of 2025, starting January 1st. So it's really great, timely information here as you're making those decisions. If you're not already participating in an ACO, what should be some factors for consideration? And we'll talk about that later today. And then if you're already part of an ACO, Zach and Paul and Melissa are going to explore ways to improve performance and look at performance in alternative payment models, both in the ACO space as well as in commercial Medicaid clinically integrated networks. So there's a vast majority of different models out there. But with this, I'm going to really hand it over to Rita. She's going to get into some of these details. So I would like to introduce Rita. Rita Lewis is the Deputy Director of Clinical Quality Improvement in the Clinical Affairs Division at the National Association of Community Health Centers, NAC. She works with the Million Hearts team and leads the Hiding in Plain Sight sub-project of the CDC Preventing Heart Attacks and Strokes in Primary Care contract. Prior to joining NAC, Rita worked at the National Committee for Quality Assurance, working on both clinical quality measures and this NCQA's recognition program products. I'm so glad she's joining us today to share more about the national landscape in rural healthcare.
Thank you so much, Rayanne. Really excited to talk about my work at NAC and what I've been doing in value-based care recently and how that does impact rural health centers. So one note that I will be sharing throughout my slides is really also considering what health centers are in rural spaces are doing, just kind of clarifying the difference between a federally designated rural health clinic and then community health centers that are in rural spaces. But on the next slide, I'm going to talk about what NAC's strategic plan for value-based care really looks like and what we're calling the ABCs of NAC's value-based care plan. So on the next slide, you'll see the ABCs here, our strategy. What we're doing at the national level is really trying to advocate for those models for payment policies. So that includes working with CMS and CMMI to help discuss what are the things that community health centers need most, including what is needed for rural health centers to succeed in value-based care models, and what does that look like for them in terms of investment of upfront dollars, as well as building strategic partnerships. So we also are working with the state primary care associations. We're looking at the health center control networks and how they're working together to support how health centers can excel in value-based care. So that includes, are they creating their own clinically integrated networks? Are they joining certain ACOs that are national or state-based? And how that is working to support health center success. and also creating value-based care models that train for success. So this also includes our Elevate program, which is run by my colleague Cheryl Modica, that has monthly webinars, but also an online forum for health centers to connect and talk about best practices for excelling in value-based care. So I'll be sharing more information on Elevate, but wanted to kind of highlight these three things that are really supporting health centers. And the great thing about the state of Texas is that while there are just over 1,300 health center organizations across the country for a total of almost 15,000 sites. When you look at those nationwide, Texas has 72 of those organizations, and that's not including all of the sites, and that's just second behind California. So thinking about the influence that Texas has in the health center space, including those health centers that are in rural spaces, Texas is going to be a big player in terms of how you are excelling and setting some trends in terms of value-based care and how you're working in that space. I know we've also worked with the Texas Primary Care Association in their work in moving health centers towards value-based care. On the next slide, I'm going to highlight a couple of the program that CMS has out. And thank you, Rayanne, for the head start. I won't highlight MSSP too much, but here is just kind of some ongoing details to help differentiate the value-based care programs that exist. So with MSSP, as Rayanne mentioned, there are ongoing application deadlines, but really it's to encourage the hospital groups and health centers and primary care practices to work within an ACO to move towards value-based care. The MSS-AIP is really leaning towards the newer and low revenue ACO. So once they're getting started, because what they're going to do is provide some integrated like funding and advance payment for them to advance investment payments to help them succeed in this MSSP model that is similar to that. So it also helps them support to be able to move into downside risk, which may be difficult for newer organizations that don't have that upfront and kind of heftier bank of money to do that. With ACO REACH, we're also looking at Medicare, newer ACOs, and high needs populations to really make sure that we're looking at organizations that are really trying to improve how they're providing care for patients who may have more ongoing and chronic conditions. That does have a deadline of December 31st annually, but it really is looking at how can we take the more traditional Medicare models and really make sure they're working in underserved communities, which can include rural health centers and looking at, with migrant populations, people have low access to healthcare, chronic conditions. With the AHEAD model, they have two different cohorts that are already in place. We just want to share it here so you can see that it's also a model that CMS has that is also less Medicare focused as well, and also focused on high needs population. So many of them are kind of shades of a different product, but you can see what options are out there if you're working in a Medicare ACO or looking at traditional Medicare to provide and move into value-based care models. So these are the first four. And next, I will cover the final four models as well. So you may know of ACO Flex. It does have a deadline coming up of August 1st. So typically they're looking at low revenue ACO, so similar to MSSP, AIP, but also make sure they're accepted into that shared savings program. It is a 5-year model that is looking to kind of pilot out a couple of new primary care models, and also looking at how they can do more upfront investments and what difference that makes, and is that necessary to help more ACOs move into value-based care rather than just being in fee-for-service. Now, Making Care Primary is also Medicare, so we'll talk about a lot of Medicare models here, and that one has already closed. And the good news about Making Care Primary that's very exciting is that while it was only in 8 states, so it doesn't include Texas, so sorry about that, but of the chosen 132 organizations, 55 of those were health centers. So it's been really great for us to see how that works and how health centers are excelling and comparing to more traditional primary care practices. But similar, they're trying to look at those low revenue ACOs, how can they support them? Because with value-based care, you're looking at how are you changing your revenue funding cycle. So if you're looking at you're getting money for every service, you know what to expect. What may be different with value-based care is you have to kind of take that for lack of better words, take a gamble to say, if we put this investment to our patients, it may not mean that we're getting payment for every service we're providing, but that benefit to the patient of improved outcomes, lower cost of care, reduced readmissions, lower costs of what needs to keep them healthy. It benefits the plan and the ACO overall because that's less expenditures going out to keep that patient healthy. So it does take some, so upfront, it can be straining on the finances, which is why we're also looking at these models that provide upfront funding for that transformation, for staff training, systems changes, so that there is an accountability for that loss of initial revenue, but the long-term outcomes, look at the long-term progress and the long-term impact to the financial status of that organization. The final two things here, I'll try and be brief as I want to be mindful of time, is TIMA, which is the Transforming Maternal Health, and IBH, Integrating Behavioral Health. Those are new models. They're still putting out webinars about them, but they're looking at improving maternal and postpartum care and primary care practices, and also how does integrated behavioral health improve a patient's outcomes over time. So to continue on the next slide for the value-based care perspective, we also have the land levels. So we're also thinking about how are we moving across and how these different models fit into these different categories and how your, I guess, progress is going and transformation is going. So many organizations are in category 1. That's the fee for service. That's what we traditionally know is you have a service, you get paid for it. But as you move into category 2, that's looking at, are you getting paid for improved performance measure outcomes? So that could be a HEDIS measure, it could be a CMS measure of improving blood pressure, improving diabetes outcomes, and you're getting paid for that, but still fee for service for general care. As we move into land category 3, we're looking at now there's shared savings. So as you know, we're looking at, hey, we've provided some improved outcomes, we're cost sharing that payment. So your Medicare or Medicaid plan will share with that or ACO or organization the shared savings and reduced costs. The category 4, and you'll see there are a couple more details there, it moves into downside risk. So there's the upside part if you do the improved payment that or improved cost sharing, then you get a bonus for that. But there are penalties if you do not demonstrate meeting certain metrics or certain milestones for cost sharing in category 4. And I think that's why a lot of these CMS models are looking at how can they support lower revenue ACOs or health centers that don't have that buffer to have the penalties, which is preventing them from getting to category 4. So that's what we're looking at, the population-based payments of how can we help organizations that don't have that buffer succeed and move along in that space and not become stagnant and stuck in category 2 or 3. Now, what NAC is doing to at least support health centers, and the next slide is kind of why transform. We know that health centers and primary care is a great space to start in terms of looking at wellness, looking at expanded workforce, training, and making sure patients are getting the best care possible. So for us, we're looking at how can we, look at what's not working, focus on sick care, and focus on well care. And that's moving into those categories 2, 3, and 4 for the land levels. And that's why we say it is important for us to transform out of fee for service and into this whole person care and moving to these payment models, because it really helps not only the patient, but the healthcare system overall. And I'll put the links in the chat, but on the next slide, I have more information about our Elevate learning platform. That it is for health centers, but we do have the monthly webinars and all can tap in and listen to the recordings. But it looks at how are we supporting health centers through a value-based care assessment to see where are they at in their transformation process? What are the key things that they should be focusing on and be able to tap into and elevate themselves to the next level and step-by-step guide for moving them into these more value-based care models and products. So I know it's a lot of information here, but want to kind of lay the framework for what NAC is doing to support health centers, including our rural health sites in Texas that are so important, but also nationally what that looks like in comparison overall. I think one thing to keep in mind is that CMS is trying to move all Medicare patients into a value-based care model by 2030. So it's not something we can just ignore. 2030 will be here before we know it. We're already halfway through 2024. So I think it's really important, a really important thing that we're doing now to help people prepare and get them moving forward into value-based care models. And with that, I'm all done.
It's fantastic, Rita. Thank you so much for the information and the resources. I think this is a valuable information that, anyone can lean on. Like you're saying, it's NAC is supporting the How You Elevate information that's free to anyone. But it's also a good reference to reference your other national associations. I'm sure there's lots of value-based care information out there. And if you haven't already done so, they have resources. Do you mind expanding a little bit on LAN and what information is available through LAN for those that might not know?
Yeah, absolutely. And I can put their link in the chat, but they're an independent organization that looks at value-based care and care transformation. So they've kind of created this model in addition to other organizations to say, what does it look like to be moving throughout the transformation process and to move into various levels? So that's where they kind of have the different categories of what that looks like. So it's not necessarily anything that NAC has created, but we definitely follow along, and CMS bases their products around the different land levels of moving out of fee for service and into more population based and value care based payment. I know at least where a lot of health centers get stuck is that category two, because I know what many primary care practices, it's very scary to change how you operate and how you work. And just think about what does that cost income look like for maintaining staff, maintaining services and outreach for patients. So much of that is looking at how can we help organizations see the value in not just getting paid for, every individual service, but looking at the overall benefit to providing care management for patients that helps them manage their diabetes and helps them reduce the need for amputations, which are more costly, or higher A1Cs, which requires more medication, which is more costly, and overall a better quality of life. So I think it's how do we translate what we know works in healthcare to the patient, and then everyone wins in terms of reduced costs and better outcomes as well.
Fantastic. Thank you so much for sharing.
Yeah.
My pleasure to introduce Zach Davis. Zach Davis joined Wakely Consulting Group as a senior consulting actuary in 2023. He has a wide range of actuarial experience helping both payers and providers manage risk. His current focus is helping ACOs manage insurance risk through their value-based care contracts, whether it's in MSSP, ACO REACH, Medicare Advantage, or commercial markets. Thank you so much for joining us, Zach.
Thank you for having me, Rayanne. Rita, has enjoyed your presentation. I think it was a really good way to tee up some of the stuff I'm going to talk about today. So just a quick overview. I'm gonna dive into a comparison of MSSP versus ACO REACH, some of the key considerations, then go into a little bit more detail on who would be beneficial to join a primary care flex model, and then think about how to generate savings or maintain savings kind of from an actuarial financial perspective. So things ACOs can do to help improve their shared savings. So just jumping in here for MSSP versus REACH. From a program authorization standpoint, I think people use CMS and CMMI interchangeably, but that's actually not the case. MSSP is a permanent program that is written into law through the federal government. So if you need to make a change to that, you need to have that done through the legislative process. ACO REACH is actually a program within CMMI, which is the Innovation Center. And so CMMI has control over what programs come out of that. And so there's a slight difference. But the thing about ACO REACH is that, and other CMMI programs, is that they end. And so if they don't show an improvement in savings or an improvement in the quality of care, then they aren't extended and they end. So I think there's been about 50 programs that have come out of CMMI, and about 5 or 6 of them have been continued. Okay, so that's the kind of the program authorization. From a membership perspective, MSSPs, you need to have 5,000 beneficiaries to join, or you need to join an existing ACO. So if your ACO or clinic has that membership, you can start your own ACO, or you can combine with other clinics in a region, FQHCs in a region, and join together. Or you have the option of joining with an an existing ACO. So the pros and cons there, with an existing ACO, there's some infrastructure. They can give you some reporting. There may be also some wraparound options around, do they give you some support from EHR or risk scores or, financial support from like a financial team perspective. So there's some advantages of joining an existing ACO. I guess the idea of having your own ACO is you can control the outcomes. You're in control of what the best initiatives are, how to spend your capital to improve the care of your beneficiaries. Reach is actually closed for applications. If you want to join an ACO Reach, then you can join an existing ACO Reach. So the similar stuff applies. You would be part of another ACO, and you'd have to kind of follow their rules and guidelines. ACO Reach, I put up in the first bullet there, is expected to end in 2026, but there's some speculation that either it will be continued, there will be a Reach 2.0, or some of the key components related to risk, the risk tracks could be moved into an MSSP option. So thinking about the risk tracks, MSSP, you have a wide range of options from no downside risk in tracks A and B, and then as you get to track C, D, E, there is some upside and downside risk, and then when you get to enhanced, you have the 75% upside with the enhanced track. In ACO Reach, there's two tracks. There's a global, which is 100% risk. So if the ACO generates savings or losses, they're responsible 100% for those. Then there's a professional track, which is a 50-50 split. From a risk score perspective, both of these models have a very similar methodology. They use the CMS HCC prospective risk score model, and both have a 3% cap. So from your reference year to your performance year, there's a 3% cap on the population. So that cap is calculated slightly differently between Reach and MSSP, but it's very similar methodology. From a benchmark perspective, the MSSP is going to be the 3 years prior to your first agreement year. So if we take 2025, if you start a new ACO in 2025, your 3-year historical benchmark would be 22, 23, and 24. And so those years would help establish the benchmark for your 25 performance year. ACO Reach is set. The 3-year benchmark is based on 2017 to 2019. From an attribution standpoint, MSSP gives you two options, a prospective and a retrospective. So prospective is what your beneficiary list is, who's attributed to your ACO before the start of the agreement period. Whereas the retrospective, you manage beneficiaries throughout the year, and those that saw the plurality of care, had the majority of their care done at your clinics or a clinic within the ACO, would be attributed. So there's some advantages and disadvantages to prospective versus retrospective. With retrospective, you get a little more lives. But you don't ultimately know who you're responsible for until the end of the year. Prospective, you get a list of who historically you've served in the past, but you don't necessarily know if they're going to continue to, drive their same patterns that they did in the past. So that there's kind of pros and cons to both. MSSP has a 1-year look back. So, for 2025, the look back period would be, did you have the plurality, the most services for this ACO through September 30th of 2024? Whereas ACO Reach has actually a 2-year look back. I believe it's a 1/3 for the farthest year and then a 2/3 blend of the current year. And so there's a slightly different methodology for those two. So those are just kind of some really high level comparisons, compare and contrast for MSSP ACO Reach. Rayanne, I joined a little late trying to get in, but were we taking questions after, or this might be a good time to see if there's any questions about the two programs?
If anyone has any questions, feel free to enter them in the chat or come off mute. And we can also address them at the end as well.
Okay, sounds good.
At this time, I don't see any in the chat,
Okay.
so we'll keep an eye out on it for you.
Okay, we'll go to the next one then. All right, so primary care flex, as Rita mentioned, the application is due on the August 1st, but actually you had to indicate you're interested by June 17th. So that deadline is passed. There may still be options if you're interested to join a prospective ACO that is interested in getting into primary care flex. So happy to help facilitate that if anybody's interested in doing that. But so the questions I always get is like, is PC Flex right for me? And I think there's a couple of questions you need to be able to get answers to in order to answer that. And the first one is, does my ACO generate a positive regional adjustment or prior savings? So if the prior savings is if you participated in ACO or MSSP in the past, then you get some of that savings you generated. Let's say you generated $500, you would get 250 of that, half of it back as an add-on to your benchmark for your new agreement period. If you generated a positive regional adjustment or a prior savings, then the math doesn't make as much sense for joining PC Flex, and we'll talk about that a little bit more on the next slide. And then the second one is, if your county benchmark is above historical spend, can your ACO invest the extra dollars and generate a positive ROI? So the way PC Flex works is it goes and looks at and says, for the average of all the counties your members are enrolled, what is the cost of primary care services? And it gives you that dollar amount as like a capitation upfront payment. Then it goes and removes all your historical spend. So any primary care services that are included in this capitation are removed. So that creates a delta, a difference between what you got paid and what you historically got paid. And in order to make primary care flex work, you need to be able to take those additional dollars and invest them and then into your care management programs, into your providers, into your whatever it may be, and return some investment on that. And then so reduce your non-primary care services by that amount. So if you got an extra $20 per beneficiary, you need to reduce your non-primary care services by $20 in order to generate at least a 1-to-1 ROI. If you can do that, then, and you think you can, if you had extra dollar for your clinic, then you could spend those dollars and reduce other costs. Then I think ACO PC Flex makes sense. And then from a risk track perspective, the lower the risk track, the more advantage. And again, we'll jump into some of those numbers on the next slide. So maybe we can just jump right in there. Okay. So on the left, we have a scenario, should be very similar scenarios on the left and the right. But on the left here, there's a scenario where there's no regional adjustment, no regional efficiency. So you had no prior savings and no regional efficiency. So in the kind of the middle column here, the regular MSSP payment year one, you can see that the regional adjusted historical benchmark was $10,310. The ACO expenditures were $10,310. So in this scenario, the ACO broke even. There was no shared savings. There was no shared losses. All right. So in the second scenario here, you're getting a $485 primary care flex county capitation, $125 capitation. Now, your historical spend for primary care services are $360. So that's the delta that we talked about on the last slide. So you right off the bat, you can see here your expenditures are now coming in higher than your historical benchmark. And so from a gross perspective, you're losing $125. Then you have to pay some of that to CMS. And so you've lost $92. But the thing PC Flex does is it gives you this enhanced offset. So this enhanced credit. And so you get an extra $125 after the CMS reconciliation. And so now, even though if you historically participated in MSSP, you would have lost money, this extra $125 you end up generating $33 after the final reconciliation. And that's because the regional offset, or the enhancement is offset by the regional efficiency. And so when you have no regional efficiency, there's no adjustment to your enhanced credits. Whereas if we go over to the one on the right there, we can see the $200, we start with a $200 regional efficiency. Since it's greater than our $125 enhancement, we actually get 0 credit for that enhancement. And so that's why I think that the way CMMI designed this program was for those that weren't regionally efficient, had no prior savings. This was a really good way to get money funneled through to the ACO without having to have generated starting from a positive position. So I really think this is a good program. I think CMS and CMMI bobbled it a little bit by not rolling out the specs, the request for application early enough, and then only giving the ACOs or potential ACOs about 30 days to decide. I think this is a really good opportunity, especially for low risk ACOs that are trying to get in, or the FQHCs, I think, are really going to be helped by this. So this is just a financial scenario to kind of show you that if you're thinking about getting into a low risk track and you have no historical experience, that it could be a good option for you. All right, next slide, Rand.
Yeah, and I don't think we have any questions yet, but I will just add, this highlights the complexity of the programs. And as a provider, participant, hospital, your ACO could be approaching you in these new type of models. And it's important to have that actuarial review and consultative review to help understand if it's the right fit for you.
Yeah, it's definitely worth having an expert think through this at the beginning, especially before you get into any agreements. That's a really good point. Okay, so these are things I think about from an actuarial perspective on how to improve the performance. Some of this stuff can be done in the current year. Some of it is kind of thinking about your performance for next year. So I'm not going to read this list because I got a slide for most of these. So let's just jump right into the first one here. So cost and use reporting. Maybe this is an actuarial term, so I'll define it a little more. But the way we think about cost and utilization is on a monthly basis, on a normalized basis. So if you have 1 million members, you convert it to the view into a 1-member view. What is the utilization for that normalized population? And so what we like to do is we like to compare on a monthly basis what the key categories are doing over time. So like the first column there, or the first row, inpatient facility medical. So these are the medical admits. And you can see here in 2022, there was 140.3. And then now in 2023, there was 129. So that's a pretty good decrease. And so what we do as from an actuarial perspective is we monitor these to see what is changing, what are the key categories that are changing on a monthly basis. And then when we see something that looks out of ordinary, we dive into the detail, into the more detailed claims, and try to understand, okay, what is really driving that 11 utilizations per 1,000 number? And is that consistent? Is that just a macro thing? Is everyone in the US seeing that decrease? Is that just Atlanta, Georgia, where I live, a thing? Or what is really driving that? And so when you have your data broken out into this cost and use view, it can really help you understand what is driving your cost and utilization. So this is the utilization view, but you'd have a similar layout and setup to show you what is the cost for inpatient medical services, on a unit cost, or how much is each service cost, or and also on a PMPM cost. So this is a really important one. Jumping in here to this is what we call network optimization. So as part of your ACO, when you're looking to see who should join your ACO for the next year. So let's say we're trying to put together our ACO for 2025. We want to look and see who's performing really well historically. So if you look here, I think we've got, I don't know, 12 or 13 tins on this visual here. And what we did is we created each tin as if it was its own ACO, its standalone ACO. And then we looked at how much profit each of these tins on their own were generating. And so you can see here, there's a lot of big blue bars. So these are all ACOs or tins that are generating more profit or more than average shared savings. And then you see you have 4 that are below the green bar, and then 2 that are kind of negative. And so if it's an option, if you're able to hit your minimum membership and there's not a disruption of removing a tin, then you could consider, potentially taking tin 8 and 9 out of your network and saying, hey guys, you're not ready for full shared savings yet. Maybe we can put you into another ACO that has a lower risk track, or maybe work on some of the other things that we're going to talk about on the slides. And then next year, if your performance improves, then it's time for you to get into a risk based arrangement. So this is a way that you can look at your network, your group of ACO participating practices or TINs, and see what's driving savings. All right, next slide. So risk coding, I think it's one of the unfortunate things about MSSP, ACO REACH, Medicare Advantage is that there is this constant risk coding initiatives that you have to have, and the thing is, risk coding is about being a better than average. CMS takes how much the risk scores have increased each year and then ratchets everyone down by that amount. And so if you're not increasing your risk scores by at least the average, then you're losing money. So risk coding is a necessary evil. So it's important to look at your recapture rates, look at things that are impacting your risk scores, like the change to V28, and then always looking for risk score opportunities. Were there members that had conditions in the past that aren't currently coded? I think those are probably the things to focus on. So attribution, we talked a good bit about retrospective, prospective. The thing I think about attribution is really just making sure you understand who's on your list. From a prospective attribution, it's important to make sure that you're getting your members your current members, getting them in during the year so that they're attributed next year. From a retrospective standpoint, in MSSP, you get a quarterly list to say who is currently attributed to you and who dropped off. And so from a retrospective standpoint, on a quarterly basis, it's important to go through your attribution list and say who dropped off from the last quarter, and make sure your care coordination team, care management teams are reaching out to those beneficiaries and getting them signed up for, come back in for a visit, wellness visit, or a checkup or whatever it may be, to get them back and attributed for the next quarter. Contestation included this one. This is for, a lot of times ACOs are participating in multiple programs. So, they have a MSSP, they might be in Medicare Advantage, they might be in commercial risk contracts with payers. And so contestation is really a terminology related to non-fee-for-service ACOs. But from a standpoint of the payer, you're in a Medicare Advantage or a commercial arrangement, risk-bearing arrangement, and the payer is telling you who's attributed to you. And they give you a big, long methodology of how they develop attribution. So it's important to understand, is this member really my member, or are they falsely attributed to me? So that's the one side. And then conversely, am I seeing members? Do I have members in my EHR that I'm seeing on a regular basis that I know are attributed to me or my ACO? Are they on the list? So looking at your attribution from 2 perspectives, do I have members that aren't mine, and are there members that are mine that aren't on the list, is really a good way to make sure you're capturing all of the shared savings, and you're not responsible for members that are yours, or sorry, that aren't yours, but are falsely attributed to you. So, okay, so The actual to expected, this is a like an actuarial term. It's basically so when you're doing an analysis, you develop some assumption. That's your expected result. What is my trend going to be for next year? And then the actual is whatever, when you get to next year, what happened? And this is on LinkedIn. I'm big on LinkedIn. So anybody that wants to follow me or join the conversation on LinkedIn, I encourage you to, but I try to post a lot. But this is one that got that resonated a lot with some of the community on LinkedIn is your ACO shared savings last year could have been because of your great initiatives you implemented, or it could have been a random fluctuation in your population's healthcare consumption. Make sure you know the difference. I think it's just really important to know, is this savings generated from my initiatives, or is this savings just random? And I think diving deeper into the data, doing some analysis, and being able to answer that question can help you decide if I want to continue investing in these care management initiatives that we did last year, or maybe it was just random and we need to shift and put focus, energy, capital to somewhere else. So it's really important to do this, what I call the actual to expected. And then two kind of just random ones here. ACOs that participate in a clinically integrated network or part of a health system. It's important to make sure you don't have network leakage. So, and then related to that, specialty care. So, you don't want to refer out of your network. So if you're in a clinically integrated network, you want to make sure you refer in the network. And then from a specialty care perspective, CMS is really pushing hard to bring the specialist into the value-based arrangement and help and have them share risk as part of ACO. So there's going to be a big push over the next couple of years with integrating specialists and making them responsible for some part of the risk related to an ACO. So having those conversations now, understanding what your current referral patterns are, understanding if those referral patterns are generating a positive or negative ROI, even if it's just understanding what the current methodology is it, you just take the first doctor in the list that starts with an A, and we always refer to all our musculoskeletal patients because that's the doctor's first name starts with an A or last name starts with an A. Like, just understanding what your patterns are to refer to specialists, and then thinking if you can make that a little more sophisticated and direct the care to the specialists that are performing the highest quality, the lowest cost. So those are my slides. If there's any questions, let me know.
Thank you, Zach, so much. Really highlighted the complexities of APMs, but really getting down to the data. You got to have data-driven initiatives and insights. So if you aren't seeing this type of information, you're participating in an alternative payment model, you should be asking your ACOs, CINs, your partners that you're collaborating with for the information so that you can have boots on the ground initiatives to really deliver that high quality of care. So I'm going to and it's a perfect segue into clinically integrated networks. Let me introduce Paul Aslan. He's the executive director of the Texas Organization for Rural and Community Hospitals Clinically Integrated Network, also known as TORCH CIN. He's also the president of Care Advance, an organization dedicated to assisting hospitals in Texas with the ATLAS program. He also owns Strat Health, a consulting company helping hospitals with adoption of AI tools for operations. With a distinguished career in healthcare administration, Paul has held several leadership roles, including COO and CEO of rural Texas hospitals. In addition, Paul serves on the HHSC Value-Based Payment and Quality Improvement Advisory Committee. Along with Paul is Melissa Matlock. She serves as a population health and quality analyst for TORCH CIN, where she oversees the implementation of innovative programs designed to enhance the quality and accessibility of healthcare in rural communities. Her work includes spearheading the quality performance of the TORCH CIN that aims to provide coordinated, high-quality care through the collaborative. Melissa has held various leadership roles at rural and urban hospitals, focusing on strategic planning, operational excellence, and value-based care initiatives. She also served in prior years on HHSC's Value-Based Performance and Quality Improvement Advisory Committee. Welcome. Thank y'all for joining us today.
Thank you, Rayanne. So in 2015, I was managing 8 district projects. Those were programs that came through the 1115 waiver in Texas, meant to create innovative ways to deliver care and increase quality. Um, I was about 3 years into the program at that time. We had urban centers that were approaching us saying, "You guys are having such great quality results. What are you doing?" And one of those programs or projects was getting PCMH accreditation through NCQA for one of our primary care clinics. So we went through that process, we achieved the accreditation, and I reached out because I saw one of our payers had a program where they said, "We'll pay you a per member per month if you achieve this accreditation." So I called them up and said, "Hey, we've got this accreditation. How can we participate?" They said, "Well, let me take a look." And I got a call a week later, and they said, "Paul, you can't. You guys are just too small. You don't have the population." And so that's really that's an example of one of the reasons that the CIN was created. So here's some of our guiding principles. We're better together. So one of the first things is it gives us some leverage by bringing those populations into a smaller group, and we can then participate with the payers through that. We wanted to reimagine rural care, which really means provide quality care and have a focus on that. We also wanted to create some financial sustainability. So our contracts are meant to provide incentives and really support our rural hospitals and clinics. We have appropriate pacing on there. We didn't put this out to all 158 members of Torch. You'll see it a slide in a minute that we've grown over time, but we wanted to make sure that we brought the right people on board. And then with my team, which includes Melissa, and we have a credentialing coordinator, we relieve some of the administrative burden on participating in advanced payment models. Next slide. So this actually needs to be updated again. When I started 2 years ago with Torch, we had 9 hospital members. Today we're at 35 hospitals and about 65 clinics. So we've had a lot of growth during those last 2 years. Next slide. And this is how we operate. So we're we're a separate entity, but we're a subsidiary of Torch. We have an operating agreement. We do have a board of managers, a clinical committee and contracting committee, and then our administrative staff. And then we have a participation agreement with the member hospitals. I'll tell you that looking at how we're performing this year, some of our members are on track to receive over $1 million in incentive payments. We have a traditional ACO agreement through CVS. We have an incentive program through Main Street Rural Health. We have a couple of Medicaid incentive plans, and we also have a commercial product. We're looking to grow and add to that and continue to grow our membership as well. And so the next slide is Melissa's. I'll let her talk about more of what we do to achieve those quality outcomes.
Thank you, Paul. Yes, one of the passions that I have is helping rural facilities along the journey that Rita was describing down that land continuum. It requires a lot of foundational learning when you are going from fee-for-service all the way over to value-based care. And so, my goal is for all of the members of our CIN to kind of learn some of the foundational principles of value-based care, of participating in a lot of these programs, ACO success. And so one of the things that I do is I try to focus, if you could do one thing, how do you begin? And for our members, we are suggesting to them that they adopt one thing, and that is pushing towards an annual care visit for all patients, all payers. So, annual wellness visits, annual care visits, whatever you call it. We would like to create that standard of care for all patients in our rural clinics, is that they get a preventative care visit once a year where, their gaps are closed, their screenings are done. And, this is a foundational quality initiative that sets the members up, the providers up for success upon, a lot of these different measurement categories. Some of the things that our staff does, that I do, is, I work specifically with them to give them opportunity reports from all of their payers. We put cohorts together to group those with like EHRs. So we've got different groups within our CIN, and we're setting them up for success, training for success, as Rita says. And then, different things like toolkits to, target their achievements and the things that they're moving towards. Next slide, please. And why is it that we selected this annual care visits to be our focus? It's really because as you look across the spectrum, it's the biggest lever that we can pull, that you as a provider can pull to improve your performance and your quality. As far as engagement, it measures what you're doing. It helps you engage with the patients and deliver patient engagement. That's what you're doing through these ACVs. And as far as management, you're documenting and you're doing the very important work that Zach was talking about with your risk coding. Very important. So you're identifying these gaps, documenting, making sure that your stratification is appropriate, your risk scores. It's so the documentation, and then these ACVs. This is where you get your performance. Most of our value-based quality measures are clinic-based. And so we can capture them and, trigger those important actions on screenings and other visits through these. So, we really try to make it easy to bring new members into our ACO, to our CIN. We start, we all are learning, and we're coming into it, and we're making an investment in learning together. Paul said, better together. We do achieve that leverage, that contractual leverage with, more people, more bodies, more lives in these groups. But also we get a statistical advantage as well. We get leverage when we start talking about larger denominators. It's easier to share the risk, to share your performance with a larger group, so that it's not so volatile when you have such small numbers. I mean, I come from a rural hospital and a rural health clinic. I know how difficult it can be to meet your quality measures because they're very volatile. If you've got a small denominator and a few people pop into your numerator, it's difficult to thread the needle there. So much easier to join an ACO or a CIN so that everyone's performance can smooth out those curves a little bit. That's some of the layer of support that we offer our members. And, I know we're right up on time, but would love to entertain any questions and make sure that you can follow up with us afterwards.
Thank you, Melissa. I really appreciate it. Thank you, Paul. Yes, if you have any questions, feel free to put them in the chat. We can always follow up afterwards. I know we're at time, but really the message is better together. Through these partnerships, we can help navigate these alternative payment models, especially in the rural setting. So I'll turn it back over to Cassidy.
Thank you, Rand. We just had a question drop into the chat, and it looks like it's for Zach. Regarding the information on CMS's 2030 goal to have all Medicare patients on an accountable care TCOC model, how will this affect cost report-based reimbursement?
Report-based reimbursement. I'm not sure what cost report-based reimbursement is, but from a CMS's 2023 goal, that leaves probably 16 million fee-for-service members that aren't in an ACO to get in there. So there's a huge opportunity for to get probably more than half of the fee-for-service members into a total cost of care model by 2030.
And just to add on to that, it is incremental over the years. So there are goals for like 2026, 2028 to get to 2030. So I think it's more of we want people to start now than to wait, because transformation doesn't happen overnight. As Melissa was saying, and everyone's been saying, it takes time to get to certain levels and certain stages. So no one's saying you have to jump from fee for service to land level 4 overnight. That's not realistic. Even going from land level 3 to downside risk is very difficult. So it's more of getting familiar now, starting now, so that by 2030, you're maybe in a land level 2 for first few years, and then work on the steps that it takes to get further along. But at least you're moving towards value-based care. I'm not quite familiar with the cost for reimbursement either, but essentially what CMS is trying to do is recognize that fee for service is great, but it doesn't move the needle for quality. And that's what they're really looking at. What is going to be the best type of interventions and services that give the best outcomes for patients and for cost savings for what it costs to care for patients over time.
Excellent. Thank you, Zach. Thank you, Rita. Since we are right at time and there are no other questions in the chat, I will go ahead and close that. But if you think of a question after we adjourn, please just send anyone from the presentation an email, send myself one, and we'll make sure the presenters get it. I just dropped 2 links into the chat. The first one is the Texas A&M Health Rural Engagement Program website, and the second one is our technical assistance inquiry form. So if you have any questions about any of the stuff that we talked about today, then you can use this link for this form to submit an inquiry and find out more about how we might be able to support you with that. But I want to say thank you to Rita, Zach, Melissa, and Paul for excellent presentations and information. Thank you, Rayanne, for moderating. It was a pleasure being with all of you today. And we look forward to seeing you on our August webinar. Thanks, everyone.
Thank you.
Thank you.